From Case Western Reserve University School of Medicine in Cleveland, Ohio, I'm Christian Essman, and you're listening to All Access Med School Admissions. Hello again, everybody. Today I'm talking with my friend Dr. Joel Maurer, the Assistant Dean of Admissions at the Michigan State University College of Human Medicine. Dr. Maurer is not only involved with admissions, but also very much in the medical education piece as well, which I'll tell you about in a minute. But before we get to my discussion with Joel, here's some background on Michigan State. The Michigan State University College of Human Medicine is located in East Lansing, Michigan, which is about an hour and a half slightly northwest of Detroit. MSU is a public institution and was founded in 1964 in response to Michigan's need for primary care physicians, and they've expanded in this mission and size to meet their growing needs. MSU is committed to educating exemplary physicians and scholars, discovering and disseminating new knowledge, and providing service at home and abroad. They emphasize their communities by providing outstanding primary and specialty care, promoting the dignity and inclusion of all people, and responding to the needs of the medically unserved. MSU accepts applicants from Canada, those with DACA status, and U.S. applicants with preference given to Michigan residents. In 2018, the medical school received 6,441 applications, and they interviewed 492 applicants for a class size of 190. About 27% of the class were from states outside of Michigan, which I think is important to note. 61% of their incoming class were comprised of women, and 31% self-identified as underrepresented in medicine. Based on the AMCAS matriculant data for that entering class of 2018, 89% of incoming students had community service or volunteer experiences, 82% had physician shadowing or clinical observation experiences, 90% had medical or clinical community service or volunteering experiences, 57% had some type of paid medical or clinical employment, and 87% had research or lab experience. The median GPA for students accepted to MSU in 2018 was 3.71, with a range of 3.19 to 3.96. While the median MCAT for accepted students was a 508, it also had a range of 499 to 517. The curriculum at MSU is called the Shared Discovery Curriculum, and we're going to go into some highlights about that with my discussion with Dr. Maurer. And it's pass-fail in the first 2 years. In the third and fourth years, like some other medical schools, they're graded as honors, pass, and fail for those required clerkships and courses. Okay, there you go. There's a little background on Michigan State. This interview with Dr. Maurer does come in around 2 hours, but I promise you we have cover a lot of ground, and there's a lot of great information throughout there. We kind of deviate a little bit and talk about some tips and advice along the way. And then we wrap up the show today answering listener questions about activities, the work, the experiences section of the AMCAS application, and in general life experiences that can be put into the application. So I think you're going to find it really helpful. So let me tell you a little bit about Dr. Maurer. Dr. Joel Maurer is the Assistant Dean for Admissions at Michigan State University's College of Human Medicine and an Associate Professor of Obstetrics, Gynecology, and Reproductive Biology. Since arriving at Michigan State, Dr. Maurer has developed into a leader in medical school admissions, having served and co-chaired the Committee on Admissions for a combination of 5 years, and now with his current position as the Assistant Dean for Admissions for over 9 years. He has over 14 years of experience in clinical medical education, having previously served as the clerkship director for the OBGYN department at Michigan State's Lansing campus and as the lead clerkship director for the multi-campus department. He is also actively involved in medical school leadership at the regional and national level for over the last 8 years and is currently serving as the immediate past chair of the Association of American Medical Colleges Central Region Group on Student Affairs. His teaching has emphasized women's health, including clinical skills in breast and pelvic exams, routine pregnancy care, disease care in pregnancy, and abnormal gynecological issues. He has not avoided, though, in going outside his quote-unquote specialty comfort zone, as evidenced by his teaching basic sciences in his college's new shared discovery curriculum in years 1 and 2, medical humanities, and the overseas primary care curriculum supervision. As an experienced teacher of medical students, Dr. Maurer sees the shared discovery curriculum as a once-in-a-lifetime opportunity to get involved at the ground level of this pedagogically new way of teaching medical students that is founded on experiential learning and guided by educational research. Dr. Maurer is also a mentor to medical students at MSU. He mentors and advises fourth-year medical students interested in pursuing careers in OBGYN and family medicine. He also serves as faculty liaison to student organizations such as Medical Friends of Lesbians and Gays, also known as MedFlag, and the Council of Medical Students. Man, you wear a lot of hats, Joel. Thank you for taking some time out of your busy schedule, and welcome to All Access.
Thanks, Christian. It's great to be here, and I'm excited to talk to you.
Well, this is fun. I mean, you have an amazing background and certainly are involved in a lot of things. What did we leave out? What's the fun stuff that's left out of your bio sketch?
So the stuff that is like, what is the fun stuff that I like to do, but I only let certain people know about?
Yes. Yeah.
All right. So, I do share this a little bit on our interview days with our interviewees, but, and I give the hints to this, but I'm in my middle age, in my 50s, I still, have this raver side of me, and so I'm a closet raver into electronic dance music. And in fact, tomorrow I'm getting on an airplane and flying to Las Vegas to go to the Electric Daisy Carnival over the weekend. So,
oh my gosh,
yeah, so
you're serious.
Yeah. Yeah.
That's big time.
It's fun. I have a great time with it. And it allows me to sort of harken back to a little bit to my youth. Dance music is always a big part of my growing up and a big part of my social life. Not so much as a college student, but believe it or not, maybe even more as a medical student. I went to college in a really small community that wasn't known for its nightlife. But then when I went to medical school in Omaha, it clearly had more of an after-hour scene than what I was used to, and so it brings back fond memories of things for me when I was in medical school and how I was able to cope with stress and that sort of thing. So in my mid 50s, I once a year I break back to my inner youth and have 3 nights in a row of all night dancing.
Oh my gosh, that's awesome. That is awesome. So, Dr. Maurer, you've been doing admissions now, from what we read, 9 years.
Okay.
And
yeah.
So what do you prior to that, you were a practicing physician in obstetrics and gynecology. What do you find rewarding about this admissions work?
I think the thing that really resonated me when I started doing this was sort of this sense of responsibility at some level for the future of healthcare in our region and in our country, and that the fact that a university or a college within a university allowed me to have that opportunity and responsibility was extremely flattering to me. And so that piece of getting to know the people that hopefully will be taking care of me someday at the entry level, I found that to be an extremely rewarding piece of the work that I ultimately was asked to do here. So it wasn't one of those things that it was when I first started working here. I was hired here mostly as clinical faculty, within the college and within our OBGYN department. And, it was my first venture into academic medicine. Prior to that, I had been in private practice for 4.5 years. And, life circumstances happened at the time, and I needed to try to find a new home or a new place to work in, specifically East Lansing, because if you want to follow your love, your partner, your love in life, sometimes you have to give up some things that were otherwise reporting to you. So landing in academic medicine wasn't really on my radar. But after I got here, I realized I had a great opportunity. And so I might as well take advantage of the opportunities that the university and the college provided. And so one of those opportunities happened to be an unexpected opening on the admissions committee. And I remember at the time expressing interest to my department chair at the time, and he blatantly encouraged me not to go into it, to go that route, just because he knew I was being worked pretty hard from the get-go, given some of the circumstances that I walked into. But he said, I just don't want you to burn yourself out. And at the time, it was one of those things that I really thought it seemed interesting, and they needed some help. And I thought, all right, not that I want to necessarily disobey or go against my department chair's recommendations or advice to me, but this just seemed like an opportunity I couldn't pass up. And so once I got into it, it ended up, there was something that clicked. I don't know. I think those who find ourselves in admissions find ourselves there because there's this weird resonance that's hard to describe, but I kind of felt like I was at home. And so it was one of those things that I served on committee for 5 years. And the last 2 of those years was given the opportunity and the responsibility to co-chair the committee. And then the opportunity arose for me to transition into the leadership position of the admissions area. So, and as they say, kind of the rest is history.
Yeah. These are really fun jobs.
Yeah.
we have great jobs.
Isn't it fun to get out and go to work and love what you do, especially administration? That's what I love about that, because I know some people, I think, find themselves in an administrative position, and they aren't, they find out it may be not all that glamorous and very fun. But I think admissions is one of those areas that it helps. It helps us stay young. It helps us stay up to date on what's going on in the lives and the generations behind us. So,
there's some days I drive home like I didn't even feel like work today. Yeah.
Yeah. Oh, I know exactly. So it was just I think a personal resonance with me, and I feel lucky and fortunate to have found it.
Well, you're the authority on the Michigan State College of Human Medicine. Let's just dive right into, how does one get into your medical school? So let's just start with just going right after the screening process, and kind of when you're meeting prospective applicants, Joel, what do you tell them about? How do you answer the question to them? Like, how do I get in? What do I need to do? So walk us through your screening process, if you could.
Sure. So our screening process involves, we have a number of hired help, individuals who help us read and screen applications to medical school. And so, as with most allopathic medical schools here in the U.S. and Canada, we are a AMCAS participating medical school. And so once we receive that application, we are a school that has made it as a conscious decision to send everybody a secondary application. So there is no pre-screening applications And only those that meet a certain cut then are invited to fill out the secondary.
Mm-hmm.
I think, there's arguments for both of those methodologies, and I'm certainly not here to say one is better than the other. I think from our perspective, we've been a medical school that has a long history of applying at various levels a holistic review principle to all of the various aspects of the decision-making tree that we go through that ultimately result us in getting 190 medical students to start in the fall. And so at the application screening level, we sort of feel like that the Common application does a really good job in general of giving us information, but it may not be the best for the best way for someone to be able to tell their entire story. And I think our take on it is we want to hear someone's entire story before we make that challenging decision for getting an interview or not. So
and that's where your secondary application comes into play.
It comes into a big part of that. And so the secondary application for us specifically addresses gives our applicants an opportunity to convey extra information about themselves that our committee generally finds very helpful to them in better understanding one's motivation, their goals, how they might address challenging situations, that sort of thing. And so, and so gives them that opportunity to hear more about that applicant that might resonate with us as an institution in particular.
Yeah, I think something that's important to even just kind of make a quick pause here. I mean, that right there, I think is a big pearl of wisdom, is that in these secondary applications, they're very school specific. The prompts are very school specific, and applicants need to take the time to respond to them appropriately for that school.
Right.
Because if you start cutting and pasting, well, this one looks a little bit close to this other med school, and so I'm going to cut and paste and stick it in there.
Right.
I'm sure we can pick up on this stuff, can't we?
Certainly we can. Yeah. I mean, it isn't overly challenging to pick up on certain cut and paste things, particularly, as you mentioned, if they're using similar responses for other medical school applications as well. One of the biggest giveaways is when they don't do their editing close enough, and you refer to that other medical school in the secondary application, which I promise you is a joy kill from our end. So yet at the same time, I mean, we get it. We understand too. I mean, with the volume of applications that a lot of applicants go through, and some of the lines of secondary question essays being very comparable, I understand that. But I think it also lends to the importance that you got to pay attention to detail as well. And if you don't, sometimes you'll get burned.
Yeah. There's an additional layer to your application process from what I could see, and help me with this. But Michigan State requires the CASPER test, which stands for the Computer-Based Assessment for Sampling Personal Characteristics. These are essentially situational judgment assessment, right?
Right.
So CASPER's kind of they've been doing it in Canada for a number of years. It's kind of new for medical schools in the United States, but tell us about how you use CASPER and kind of what it tells you about your applicants.
Sure. So what I can tell you, I'll back up just a little bit. Okay. Just for clarification, this upcoming application year, starting with the 2019-2020 application year, it's actually the first year that we're going to be incorporating CASPER.
I see.
So what I can tell you, at least From an experiential end of it, I don't have a whole lot to comment because this is
okay.
our first year using it. But maybe let me use this as an opportunity to maybe explain to you why it is that we went down.
Yeah, I'd love that.
Incorporating that because, I think as you would relate to and understand, a lot of medical school admissions offices have limited resources as far as trying to screen applications or whatever that process is for screening applications, trying to figure out which is the best of these applicants to bring in to a very limited number of interview spots anyway. I mean, everyone talks about how competitive it is to get an acceptance offer. Well, it's almost as competitive just to get that interview offer as well, right, for a lot of schools and for a lot of applicants. So just being able to get that interview offer is a huge accomplishment. And so what we have found and what I found based on the system of screening that we used or that we use is that we needed help in figuring that piece out, especially since we give incredibly important value to a holistic review process, meaning, and so for our audience, when we talk about holistic review, we're talking about some sort of balanced effort of weighing academic abilities, life experiences, and any bit of personal character that we can gain from you in that written application. And then that concept then kind of carries through the remainder of the admissions process through the interview and then when the committee meets and so on. But everybody sort of has this mindset of holistic review here at our college. And so what we were finding is that in our most recent cycle, we had just under 8,000 applications to medical school, of which 5,600, roughly 5,600 followed through on the secondary application. And from that 5,600, we needed to figure out which of that 10% or slightly under 10% were we going to bring in. And we can develop rubrics, we can develop methodologies in trying to do that. But I think one of the things that was challenging from the screeners' end was that we needed a little bit more of some communication consistency amongst each other. And so, so one of the pieces of trying to help us out in that is incorporating Casper into our application process. And so, I would say the biggest piece of importance for us in using Casper is it's going to help us figure out which applicants, or it's going to have a contribution to that piece of trying to figure out which applicants to bring in for interview. And so I think that was the main reason we wanted to do that, is so that we could get a little bit better sense of personal character at the written application level.
Yeah, we've explored that as well. And I think we'll be looking at that down the road. But I completely agree. We have the MCAT as a standardized examination to test all the competencies in the sciences. But then this Casper exam is another interesting layer that, like you said, can hopefully provide some consistency in looking at they have 9 pillars of things that they look for in communication and ethical and moral dilemma kind of things. It really is a very interesting concept.
Yeah. And then some other things I think include things like empathy and, like you said, there's a number of different characteristics. And so, some of those things, I think a lot of those things that the Casper is trying to evaluate are important pieces of sort of that non-academic part of being a great doctor someday. And so having a little bit of an idea of what that is coming into an interview or at the interview decision level, I think is going to be really helpful to us.
Yeah, it'd be cool to see if there's any correlation from what you saw in the Casper, to what you're, yeah.
Yeah. So, and is I think maybe what you were alluding to a little bit, because our interview structure also incorporates as one of the interview pieces a multiple mini interview as well.
Yeah, let's get to that here in a couple minutes. Yeah,
Yeah.
We're gonna talk about that, because you're the first school that I'm interviewing that has MMI, the multi mini interview. So stay tuned there.
Sure. Yeah, we can get to that in a bit.
Well, let me ask you, Joel, are there some values that you're particularly looking for in applicants to Michigan State, things that your committee places some characteristics or values that you are looking for?
Yeah. I think so. When I think of values, I'm thinking more along those personal characteristic things. And so, I think there's some values that are common amongst many medical schools that we're looking for. So clearly, we are looking for good communicators, people who have a strong sense of compassion, a sense of wanting to help others. But I think, one of the things that I find that has kind of developed a little bit into our niche is that I think our committee and the whole admissions process, and maybe even a little bit of the mindset of our medical school based on our mission and everything, is that we really are looking for people who, in various aspects of their lives, have a strong sense of social justice and civic and need for civic engagement with their communities. And so, we are a school that, as part of our mission, we very much value the contributions of people who come from different backgrounds and the life experiences that they have. And so there's a strong, compelling sense of respect for people who are different. And then along with that is the final piece of our mission, which is really trying to train doctors that are going to go out and help address compelling and meaningful healthcare disparity issues within this country, within Michigan and beyond. So,
yeah, love it.
So, yeah. So so I think as part of that, I think, the candidates that we get really excited about here are ones that can really sort of embrace that idea of trying to make this world a better place for those who are marginalized and disadvantaged for reasons beyond their control, and are excited about trying to do that at various grassroots levels.
Yeah, that's great stuff right there, Joel. Thank you so much. I think people hearing that's what people ask us, what are you looking for? And that's a wonderful response. One thing I noticed in kind of doing my homework and pouring through your data is that for last year's entering class, 51% of your entering class were in the age range of 24 to 39. Now, the majority, 88 of them, were in that 24 to 29 age range. Okay. So clearly, you guys, your school likes students that take these gap years. So tell us how you feel about that when students are considering gap years.
Sure. I think that we are... I think that for students who want to do that, we certainly don't want to approach that in a mindset of that's going to penalize you. I do think that applicant to applicant, they sort of vary in how they sort of mature through their schooling and maturing as a person. And sometimes that maturing just doesn't happen over the course of a 4-year college undergraduate curriculum. And I think for some people, it's important for them, if they haven't been able to develop other aspects of their personhood, so to speak, I think it's important that they take the time to do that, because one of the things that and perhaps you can kind of relate to this too, when we go out and we talk to fellow future pre-med or pre-health students, is that from our perspective, our goal is to try to help you apply to medical school one time, during one cycle. And so when you do that, you want to make sure that that whatever you're putting forth in that application, to the best of your ability, um, states that, hey, this is the best job I can do, you know.
Mm-hmm.
And so for some people, particularly in today's world of a holistic review kind of admissions assessment process, for many of us, going through school in 4 years doesn't necessarily provide adequate or ample opportunity for people to fully develop themselves. And so I think for that student who looks at sort of their portfolio at the end of 3 to 4 years, and they say, with the help of their pre-health advisors or any other mentoring, they say, I'm doing well in my classes, but those life experiences just seem pretty ho-hum right now. Maybe I'm the kind of person that if I I really should think about delaying my application to medical school for a year or two so that I can refocus on some of those other areas that I think will help me in my eventual pursuit of becoming a physician someday. So I would say from an admissions perspective, we're pretty open to the idea of it. We would actually encourage it for certain groups of individuals. Do we think that everybody needs to take a gap year? No. And certainly I think we all see applicants who are highly qualified in all the various areas of their life after 3 to 4 years of college. But just because you're someone who may not be, I think we would like to think that shouldn't hinder your eventual goal of becoming a physician someday. It may just take you a little bit longer to get to that point where you're application ready.
Yeah. Yeah. I couldn't agree with you more, Joel. I think sometimes I think students may be afraid because they're worried that their parents are going to be upset that they're not making that natural next step of going right into medical school. And like, are you going to be living in my basement the rest of your life? Like,
right. Yeah.
Like,
or even just maybe letting someone down, am I letting mom and dad down? Am I letting, my physician mentor who I've been talking to about this for the last 5 to 6, 7 years, or am I or is this all on me? Let myself down by thinking that I'm just not absolutely perfect after 3 years of college.
Yeah, especially if you see your peers moving on, like they are going to medical school, and you're like, well, I'm going to take a bridge year or a gap year. I think it's kind of hard to keep those blinders on and keep in your track, and not question like, am I doing the right thing?
Right. And quite honestly, I think for people, they need to sort of try to ignore that outside noise as best they can. I mean, and for some, it's a harsh reality. I understand that, but at the same time, too, for most of our medical school applicants, you're now young adults, responsible young adults, and the idea of never letting someone down is, I think, is really putting too much pressure on yourself, and so eventually. People have to sort of start making decisions for what's in their own best interest and try to ignore the noise that's around them that might be pressuring them otherwise.
And I think if I could add one more thing, I was just thinking about that students might feel a little fearful about is, well, what am I going to do for that year? Because a lot of their friends that are going to business, they're getting jobs into a career that they're kind of set on, like they're moving forward with their career. And I feel like sometimes maybe the gap year students feel like they're kind of in limbo. And what am I going to do for a year? Will I be employable? Will somebody employ me for a year, knowing that I might be going to medical school the following year? So there might be that sense of apprehension, like, I don't know, will somebody give me a job for a year?
Yeah.
And so there's a lot of unknown going into that. But if you work with your pre-health advisor, if you have one, or like you said, a physician mentor who might be able to help plug you into ideas and what other students have done. You wouldn't be the only one. I think greater than 40% of the application pool have taken or applying a year greater after college. So it's very common.
Yeah. It really is not that uncommon of an event anymore. I know back when I was, 25, 30 years ago, when I was in their shoes, that was probably not the common route, and almost all of us went straight in. But I think those of us who have the opportunity to sit on this side of the admissions fence have really grown to realize that taking a gap year or 2 or 3 or whatever that number is, not necessarily should be viewed by the applicant as a concerning thing on their part. In fact, for many of them, it's a very helpful thing in the eyes of an admissions process.
Yeah. Well, let's segue now. You've reviewed the application. You said, boy, this person, they have all the right stuff that we're looking for here. We extend the interview invitation and the interview day comes. Kind of what can they expect on an interview day at Michigan State? We've said that you're a school that does a multi-mini interview. This is kind of a unique approach to interviewing. Tell us about it. Walk us through what that interview day experience is kind of like.
Sure, absolutely. So I think one of the things that we are really excited about at our college is the programming and the interviewing that occurs on an interview day at the College of Human Medicine. So just for a little background, at our medical school, we have it's a medical school, and we'll get to this down the road perhaps, is that we use a lot of different campuses throughout the state of Michigan to educate our students. And so initially on the front end, though, they are going to school in one of two early campus communities that would include East Lansing and then our expanded campus community of Grand Rapids. And so we actually conduct our interviews in both East Lansing and in Grand Rapids.
Oh, interesting.
Yeah. And so then what happens is, we kind of view that interview day as a way for both parties to mutually share information about themselves. Now, granted, I think the applicant feels like there's a lot of pressure on them because they are there for the interview, and clearly we don't want to diminish the importance of that on an interview day. But I also think that the interview day for us has been a way for us to really exchange information about us to the applicant as well, such that when they walk away at the end of the day, they have a fairly good idea of what our medical school is all about, what our curriculum is about, what are the kinds of students that are drawn to us, what are some of the special programming and clinical programming that we offer that is consistent with the mission of our college. And so they really get a lot. And so our interview day is actually an all-day experience here at our college. And depending on the applicant's perspective on that, that's either a good thing or a bad thing. I think, the feedback that we get fairly consistently is that it is a long day for our applicants, but we feel that the benefits outweigh that in the eyes of the applicant as well. So when they show up in the morning, it starts off with a couple hours of some programming, actually, of what the history of our college, the mission, a little bit about our student body, and then we dive into a bit of or quite an extensive discussion of our new curriculum that we rolled out a few years ago. We also offer them some programming on research opportunities, financial aid, and then we also do spend just a little bit of time giving them some background on the multiple mini interview aspect of their day, so that when they get to that part of their interview day, there aren't any surprises.
Okay. Yeah, it's great.
Yeah. So that first bit of programming occurs until roughly 10 o'clock. We do bring in quite a few applicants on an applicant interview day. We'll bring in as many as 44 on an interview day. And so roughly at 10 o'clock in the morning, we split the interview attendees into two separate groups, half of which will then go do their MMI interview. The other half will then continue to have we'll go through a team building exercise that we do, and then we'll finish off with a little bit of added programming on our admissions process. So we do try to give them a bit more transparency at that time as far as what was it that led to them getting here today, what happens today, and what happens after you leave.
That's nice.
And then we also, as part of that, after you leave, we do spend a significant amount of time talking to them about the AMCAS Choose Your Medical School tool as well.
Right.
So they know exactly what to expect. From that. So
let me ask you made an excellent point a minute ago about the programming you have in place and how you want them to walk away feeling like they know your school, they know what you're about and what to expect there as a potential future student there. And I think that's important for applicants to know, like, hey, you're interviewing us just as much as we're interviewing you.
Yeah, you're absolutely right, Christian. And I think, for lots of us, we know that we're competing for the same students. Mm-hmm. And so I think, the idea of using your interview day as a way to mutually share information about each other, it can only be helpful in the long run. And again, this is very different from when I was in their shoes, 25, 30 years ago when I was applying to medical schools. You basically showed up and you had your one or two one-on-one interviews and you walked away.
Oh,
and that idea of knowing that any of the 500 or so that we bring in are more likely than not going to be a comparable number or similar applicant pool that might be interviewing at a variety of medical schools in our region. And so I think anything short of using that day as a way to mutually share information about each other is otherwise a lost opportunity. And I just didn't want, when I took over the reins 9+ years ago, I saw this as an opportunity to use the interview day in a more equitable manner.
Mm-hmm. So tell us, you said that the two groups peel off, and the one that as they circle through the process during your day, each group goes through the MMI process. How many stations are there? How long do they last? Mm-hmm. What's that all kind of entail?
Yeah, absolutely. So we run an MMI in the morning and an MMI in the afternoon. And so and in between those two, just to kind of get this in there, we do also have incorporate a traditional one-on-one 30-minute one-on-one interview with one of our first or second year medical students.
Oh, great.
As well. There's lots of reasons we do that. One of the important pieces that I think is valued at our college and by the faculty is that it actually gives our medical students a voice in the decision-making process. And so, as the committee deliberates at their committee meetings, they pay a lot of attention to the information that the medical student gathers about that candidate. So we have consciously chosen to keep both a traditional, but yet add the new MMI as well. And so with our MMI, we have a total of 8 stations.
Okay.
Each station is 8 minutes in length, and there is a 2-minute break in between each one. We also, in addition to the formal MMI stations, we incorporate a couple rest stations as well.
That's cool.
Yeah, I mean, we have found that to be really helpful. I know some other institutions who use an MMI process have not incorporated that. One of the main reasons we chose to, when we developed ours, had to do with a bit of some logistics, and because part of our MMI, or there's different ways in which the MMI is administered from a activity perspective. And so one of our stations that we have is actually what we call a collaborative station, in which two of our applicants enter the room together and they work together to quickly address an issue in which there may be some limitations of communication or that sort of thing.
That's interesting.
Right. So one person gives direction to another to complete the task. And so, part of the reason we chose to incorporate a rest station was in that really unfortunate event where we had someone that wasn't able to make it that day for whatever that reason. So being from in Michigan, we realize we are a 4-season state. Sometimes travel to the state of Michigan during certain times of the year can be challenging. And if we had somebody who was flying in from a long way away and they get delayed and they can't get there, what you do in those situations is then we eliminate the rest station for that circuit. So what we didn't want to do was create a situation where if you had a no-show that day, how do you fill that vacant spot when they're supposed to be going through a collaboration station? So that was sort of the logistical reason up front. But I also think that from a practical purpose or perspective, I do think that our applicants do appreciate just a time or two of having some downtime where they just don't feel like they have to be on every 10 minutes or 80 minutes in a row.
Yeah, I think it's very thoughtful. Because these days there's a lot of anxiety around these interview days, and the students are naturally going to feel nervous. So if there's a couple breaks in there just to kind of take a breath and get something to drink, I think that's very thoughtful.
Exactly. Or if they felt like one of those stations didn't go very well, hopefully they got that rest station coming up, and then
regroup.
Thoughts, regroup.
Yeah.
Then let's just work on really shining for the rest. And so.
How do you prepare? So do you provide students that are invited to interview with some kind of prep material prior to coming to the campus to say, hey, we do MMI here. Here are some tips on how you can prepare for our interview day here at Michigan State?
Yeah, that's a great question. They do, most are very much aware that we are an MMI interviewing school based on information that we convey on our website and the interview day process. I will say we don't give them a whole lot of information beyond that, short of some of the programming that we do on the day of. And so that programming does give them information about the different types of interview styles that they will see in the in the MMI interview, and so we go over each one of those styles. And in general, there's 3 commonly sort of agreed upon styles of interview station. There's sort of that traditional one-on-one question answer, engage in a discussion about a topic with the other person in the room sort of station. There's the MMI, though, we have also, as I alluded to, there's this idea of a collaboration station where you can actually watch, 2 individuals engage each other and gather some information about that. The last one, or the last style that we have, is something that we call role play, or the role play station, in which the applicant enters the room. And there is also the rater or the interview that's in there. And then there's also a standardized actor or actress playing the role of someone who has some sort of dilemma going on.
So it doesn't have to be medically related. The applicants don't have to feel they're coming in to have some background knowledge of how to treat somebody or.
Yeah. In fact, I will say this much. We emphasize to them that the MMI is not, or the MMI that we incorporate is absolutely not intended to be an assessment of their medical acuity.
I think that's an important thing to stress. And I think a lot of private schools that do MMI do that because you don't want to make students feel that they have to have some medical training to be successful in this interview process.
Right. Exactly. And that's not what we're looking for. In fact, I would say as a faculty, we kind of say that's our job to teach them how to do that. But we want to make sure they have the right personal character as best we can coming into medical school. And so for us, our MMI is a measurement of 7 thoughtful characteristics that our medical school is specifically looking for in our applicants. Some of them are characteristics that lots of medical schools are looking for.
Sure.
It's possible that one or two of the ones that we're looking for may not be consistent from medical school to medical school. But I think the important thing that the applicants need to sort of think about, particularly those of us who use the MMI in our interviewing process, is that I believe for most of us, we use it as a mechanism to try to measure that personal character piece of the holistic review process as an adjuvant to the written application and the one-on-one interview that you have. So
if I could go back to one thing that you said quickly about there's a 130-minute session, one-on-one interview with a medical student, a first year or second year. What kind of application access does that medical student have to the interviewee's information? Do they have full access to the application? Do they have a little bit of limited access? What do they know about the interviewee that they're going to be meeting?
Right. Now, that's a great question. And so for the purposes of that interview, they have access to their particular applicant's written application, except we blind them or we restrict their access to anything that has to do with academic metrics. So no grades, no MCAT scores. We also restrict their access to the letters of recommendation.
Sure.
And so those are sort of the main things that we restrict their access to, because we think that those are things that could unduly bias the interviewer's impression of the applicant. And so the things that we want them to have access to are the things that the applicant is directly responsible for uploading into their written application.
Mm-hmm. Any kind of general tips for students coming to interview at your school when somebody says, "Hey, Dr. Maurer, what can I do to best prepare myself for, I have an interview coming up in a few weeks. What should I do?"
Yeah, no, that's again another great question. I will say what's funny about that in some ways is during their programming on interview day, I actually give them a hint to one of the interview questions they're going to get that day. And so what I have found, and some of the feedback that I get from our applicants from that, is that they really appreciate that level, that little bit of nudging, because it just takes a bit of the edge off the anxiety of the interview day experience. So I actually sort of unofficially spoon feed them one of the interview questions they're going to get. So they at least have the rest of the morning to kind of think about how they might respond in that theoretical situation that they get asked that question.
That's great. That's cool.
Yeah. So, cool. We do that. I before anybody does that MMI, we get them all lined up in front of the doors. And before we get started, I do a quick take a deep breath, try to relax. I know this is an anxiety-provoking situation, but I usually say stuff to them like, you know what? I promise you, we are not trying to be overly complicated here.
Yeah, and to trick you.
No, exactly.
Yeah.
We're not trying to set you up here to go down a pathway of crash and burn. I tell them, I think that you're going to find that the majority of these interview stations are going to be actually kind of fun to engage in. They give you an opportunity to really show your personal character, to show a side of you that is difficult to convey in writing. And that I usually also tell them, just be yourself.
Yeah.
Because I say, you know what, please do not answer questions how you think we think you should answer questions, because usually that's going to maybe reveal some inconsistencies in what you tell us in a written application versus what you're saying to us now in person, which then confuses the committee. So,
outstanding point.
Right. What's the real person here? So I usually tell people, just be yourself, answer questions as honestly and truthfully as you feel comfortable sharing with with the interviewer. And I promise you, if you just be yourself, this is all going to go just fine.
Mm-hmm. So the day wraps up and the applicants leave. So next step is admissions committee. Take us into that discussion if you can. Just kind of how does it all pull together, and then a discussion ensues to arrive to a decision. What's that look like?
Yeah. So that's again, it's complicated and complex, but having said that, we do have an organized mechanism in which all applicants who interview us are presented to the admissions committee. One piece of the evaluation process that we haven't talked about that is an important piece is that once an applicant accepts an interview offer to us, we then forward that written application to one of the faculty members who sits on our admissions committee and ask them to do a formal rubric-driven evaluation of that written application. And so, like the medical student in their interview, we don't share everything, though, with the faculty.
Okay.
So even at that point, we hide academic metrics, so no grades, no MCAT scores. They'll not have access to Casper, okay, for that. And we hide their letters of recommendation, and we ask them to do a formal rating of just that written piece. And so when an applicant comes forward, what the committee is going to get is a spreadsheet, and an anonymous spreadsheet. So every applicant who comes forward to the committee is identified strictly by a number. We don't allow them to see a photo. We don't allow them to have a name tied to it. So we're doing everything in our ability to make sure that we are eliminating any conscious bias that a particular committee member might have in that decision-making process. So on that spreadsheet, though, and as I convey to our applicants on interview day, that's the part where everything in the application now does come back to the table. And so the committee members, they will have access to your academic performances up to now. They will have access to your Casper score. They will have access to the faculty application rating, the medical student interview rating, and your MMI scores. They'll have access to your letters of recommendation. And so they will collectively look at all of these different pieces of information. Again, try to, in their minds, categorize them in those three broad holistic review categories. They'll have a lively discussion about what I call now your application portfolio. And once the discussion starts to wind down, we entertain a motion from a committee member, and assuming it gets seconded, we then double check and make sure, is there anything else anybody has to say here? Because ever hold your peace, okay? Because we got a motion on the table, and if you have something that's important that you think is going to affect how people are going to vote towards that motion, you better darn well speak up now. And so they're given that opportunity. If there's no further discussion, it's a secret ballot vote. It's done electronically through our software system, and that software or that electronic vote then comes to me. I attend all of these committee members, and my job at the committee is to make sure everybody has a fair chance in the eyes of the committee. And so I don't have a voting say. As I tell people, it's quite possible I might have had a little bit to do with getting them there to that interview, but from here on out, it truly is a committee decision process. So my job is to kind of function as the law enforcement officer of the committee and make sure that the discussion stays ethical and legal. That when that vote comes to me, I then announce what the votes are. Do I have access to how each person voted, yes, but I only look at it if for some reason I'm not picking up everybody's vote.
Yeah, you had to be able to see
whose
something happened. Yeah,
right, whose vote didn't I get?
Yeah, so, somebody not click submit or something like that.
Right, exactly. So generally speaking, I don't look at how each committee member voted, but I get an aggregate vote. In order for that motion to pass, we require that motion pass by more than a simple majority. And so we have 15 voting faculty members on our committee. And if that vote is 8-7 in favor of the motion, it doesn't pass.
Oh, okay.
I tell our applicants this: we need that committee vote to be at least a 9-6. We ask that the preponderance of voting faculty in that room are saying, yes, you may have one of these highly coveted spots to medical school.
I hope what people are hearing here is that the amount of time and effort and how elaborate these decision-making processes are is just, I think it's amazing. I mean, how vetted these students are to get into medical school is just, it's just amazing.
Yeah. Oh my gosh.
You don't just accidentally become a medical student.
No, not anymore. They don't. I mean, and I keep hearkening back when I was there. Sort of thing. I can almost assure you, if knowing the person I was back then, applying to medical school right now, there's no way I would have gotten it.
I don't know about that.
Well, that's nice of you to say, but I reflect back on those years and those times, and I thought, there may have been some competitive aspects of my application, but knowing the extent to which at least our process vets our applicants through a complex decision-making process, really lends value to this idea that it takes more than just being a smart person.
Yeah, I think the general public, I don't know who's going to be listening to this besides hopefully pre-medical students, but to be reassured that we're not just looking for kids that are just good at books and tests. There is so many factors that go into this. It is just, these are really top-notch students and just amazing young people.
They really are. And, and I think for all of us as medical schools to kind of figure out what is our sort of niche and how can we find applicants that fit that niche is just such an exciting thing for us to be a part of.
Last question for you here, Joel, before we wrap up the admissions committee process. This is a question I like to ask everyone because I think there are not everybody gets in right away to medical school. So if somebody's waitlisted or put on your alternate list at Michigan State, how do they express their interest? Do you care? Do you track if somebody remains interested in Michigan State? Do you like getting that kind of info?
Yeah, the answer is yes. In fact, in our sort of ethical process, it's the only part or the only time in which we allow our applicants to give us update information.
Okay.
So we made a conscious decision from our application process that when that applicant at the beginning of the very admission cycle hits enter, our perspective is that you have done everything you can to put your best foot forward. And I know that there are other medical schools out there that allow periodic updates. And I certainly am not saying that that's a bad thing for people to do. But I do think that for us, it creates a set of challenges such that, say in October, somebody wants to give us an update and there hasn't been a decision made. Knowing the sheer volume of applications that we receive, we don't have a process necessarily in place that allows someone to get rescreened immediately for a decision. And so to keep the process fair for the entire applicant pool, we tell people that we will not accept any updates to your application unless you are invited for an interview and placed on a wait list or an alternate list. At that point, then we would be very much interested in knowing which of those of you remain interested in us. If you are no longer interested in us, we would
Just as
want to know
important.
that as
Yeah.
well. And as I tell our applicants, I realize that's a tough conversation or a challenging thing to convey to an institution that might ultimately extend an offer to you. But if in the end you come and visit with us and you have an interview with us and you learn all about us and you walk away going, I could probably be okay or happy there. It's not my first choice, and clearly, if it's the only school I get into, then great. But if not, then I think we want to hear that you would rather withdraw your application from further consideration, because in the end, I think all of us want students that want to be here, or be at our individual institutions. I think nobody wants a student starting in the fall or go through 4 years or more of medical school who is then grossly unhappy.
Yeah. I mean, 4 years is a long time to be grouchy.
It is. Oh my gosh. I mean, well, medical school's stressful enough the way it is. And so, if you're going to be unhappy and a med student on top of it, then that presents some challenges. And we would really rather not have unhappy medical students, at least for reasons that we have no control over. Yeah.
Right.
So if they're unhappy because of something we have control over, then we want to change that. But if it's for something that we don't have control over, then that's a really challenging situation to try to address with someone.
All right. Well, let's kind of hit the final chapter here about Michigan State. And so now we have accepted students that are happy and excited to come to Michigan State for medical school. They're diving into the curriculum. Give us, what are some of the what's a typical day in or typical week like for first year medical students? I mean, people always ask us at fairs and things like, is there time for fun? What's a typical week like? I'm trying to get some of these frequently asked questions at fairs out there so that everybody can hear them. So how do you answer those when you get those types of questions?
Yeah. So I would say, at least as a first year medical student, from a curriculum perspective, so our mindset is from 8 until 5, you belong to the curriculum, and after 5 o'clock until 8 o'clock the next morning, then you have the autonomy of ownership of that time. And so, not that I intend that to sound rather authoritarian. That's not what I was getting at. But
no, I know.
I understand that. Yeah,
it's a job.
It is. It's a job, and we tell people, in your first year or as a medical student, it's not a 40-hour-a-week job. It's anywhere from 60 to 80-hour-a-week job. And so from that 8 to 5 o'clock timepiece during the day, that's when our active hands-on learning is, when you've got ready access to your faculty. And so, at least from a daytime perspective, our medical students are, and our curriculum is designed around an idea or a main concept of learning based on a patient's symptom or complaint or concern. And this is sort of a radically different idea in how do you educate your medical students. I know a lot of medical schools, or at least when I was in medical school, that first year was you learn what's normal. The second year you learn when normal goes wrong. And then in years 3 and 4, they throw you to the wolves of the clinical environment, and you try to then work backwards from a symptom to try to figure out what's wrong and then move forward to how do you treat it and all that. What we've decided to do is that we're going to base our first year, and particularly our first 2 years of our curriculum, guided on a week-to-week basis on a particular patient complaint or concern. So, for example, in our first So as a part of our first year curriculum, we'll say this particular week, we are studying, oh gosh, we're going to study fever.
Okay.
That's the chief complaint. The patient comes in and says, oh my gosh, I've had this fever to 102.2 for the last 3 days. Okay. So what the curriculum then sets out to do is we're going to teach you what is the anatomy behind fever or related to fever. What is the human physiology going on behind fever? What's the cell biology? What's the biochemistry? What are the disease processes that lend itself to developing fever? Okay. Then there's this clinical piece that we integrate very early on with lots of simulation in the first year. And so say, for example, that particular week, you're going to have a 4-hour simulation session on fever. How do you interview a patient who has fever?
What questions do you ask?
Yeah. What questions do you ask?
Yeah.
What is the important physical exam that you want to perform? And then once you've gathered that information, what are the top 3 things that you're thinking of that are likely causes of that fever? And then once you've done that, are there any tests that I need to order that will help me narrow down this list of 3 or maybe a list of 5 or so down to 1 or 2? Let's get the test results. Hopefully it'll lead us to a diagnosis. And then once we make that diagnosis, what are the treatment and management options? So we start this process in year 1, actually, of trying to get our medical students to start thinking like a doctor right away, as opposed to waiting into their second year or their third year.
That's exciting.
Well, yeah, I think it is exciting. And one of the things that I convey on interview day, based on my own personal experiences, is that learning how to think like a doctor is hard. It's hard to take what's normal and then how normal can get broken, and then all of a sudden then jump to patient symptoms and then work backwards to try to figure out what the problem is, and then move forward again to try to treat it. I think if we try to approach it from the get-go of a symptom, let's combine all of the let's break down these silos of traditional coursework. So anatomy class and biochem class and cell biology and human phys and pathology. Let's integrate them all together into what we call an academy style of learning, meaning we kind of use a Hogwarts model for all of you Harry Potter fans out there of presenting the hardcore medical school curriculum. And that's one of the unique things about our medical school. And then we don't think that there are a lot of schools out there that are using the Learning Society model for that purpose. I think we do recognize that learning societies are used in lots of medical schools, but they may not be used very much in the way to actually deliver sort of the hardcore medical sciences outside of the humanities side of that. And so we're really incorporating a learning society model in our first and second year curriculum. Coexisting with that, we also are providing some meaningful clinical experiences for us.
Yeah, that's what I was going to get to next. Yeah. So students, when do I start seeing patients? How soon can I get out there? So how does lead us into that?
Yeah. Well, the first 8 weeks of your first year of medical school is spent from a clinical education perspective, teaching you how to be safe for yourself and safe for others in a clinical environment. And so
that's important.
Yeah, absolutely. And so we're starting to give them a skill set of interviewing skills. We're going to give them the rudimentary head to toe physical exam skills. We're going to teach them how to give injections. We're going to teach them how to check blood pressures. We're going to give them a skill set that's comparable to that of a medical assistant in an ambulatory office, such that when they are actually placed in their first year, so 8 weeks later, 2 half days a week, we are placing them in a continuity primary care office where they actually have a skill set that office can use as they are seeing real life patients then. And so 2 months later, they're seeing patients. After their very first week of medical school, they will have interviewed their very first simulated patient.
Wow, cool.
Yeah, and we record it, and then we also make them watch it in front of each other.
That's kind of, yeah.
And what's shocking, Christian, is how good they are.
Yeah,
it's surprising after only 1 week of medical school how good they are at beginning an interview of a complaint that they have no otherwise any knowledge about.
What a great confidence builder.
Oh my gosh.
Because I think that's awesome, because we've talked about this sometimes at a national level. We talked about the imposter syndrome when new medical students come, like, should I be here? Did they make a mistake? Everybody around me is so much smarter. What a great way to build confidence.
Well, it is. And I will, and for most people, it's one of those evening the playing field sort of experiences, because it doesn't matter. At least at that point, and for that, what we're watching at that point, that's not a measurement or an assessment of someone's academic abilities. And I think that's where we see a lot of imposter syndrome sort of creep into place. You put him in a room with a simulated patient for 20 minutes and you tape record them. It can be, luckily, I think they find it more of a humbling situation than what us as faculty, when we're watching it and reviewing it with them and their small group of peers, that find it to be. In fact, as I said, I'm always amazed at how great they are, even after an intensive 1 week of clinical interviewing skill training and some rudimentary physical exam training. They do such an amazing job, which again sort of lends to the credence. You don't have to wait until someone's a second or a third year medical student in order to teach them meaningful clinical training. And so I think that was one of the biggest things that we learned as we were piloting this new curriculum, was that you don't have to wait that long. It's surprising how much you can teach someone with hardly any background at all how to do a good medical interview and how to do some basic physical exam skills, and let them build from that. And the idea behind putting them in this ambulatory clinic for at least 2 half days a week and we do this through spring break of their first year, is such that when they see or start to room a patient with a particular complaint of fever, they can go, oh yeah, I'm learning about that this week. And it sort of tricks them into thinking about all the things they're learning about what cause fever. Yeah. So it's sort of like studying on the job without really thinking that you're really studying.
Yeah.
So we're big believers in the sort of that learning by doing, learning by actively engaging the material.
What kind of feedback do you hear? What kind of things do you hear from your current students that really like this? Like what things do they say to you?
I think, it's interesting because I think every student kind of comes in with their own preconceived idea of what this might be like. And so, of course, you're going to have those students that are just like, oh my gosh, this is awesome. Or there may be some that go into and go, oh, this isn't what I thought it was going to be. And that's okay. I think where the light bulb really goes off is when they go into their third year clerkships.
Yeah. Yeah.
That's where I think they really, when they look back on this, they go, now I get it, why they had me do the things that I was doing in my first year, in my second year, and why they had me shadow or have me spend 2 weeks with a non-physician healthcare provider like a hospital-based social worker, or 2 with a physical therapist, or a respiratory therapist. That's when those light bulbs start to go off, because at the time, I think when they're experiencing it, for some students, they go, well, I should just be studying. I should study
Yeah,
that
I'm,
more
I'm
licensing.
so glad you said this, Joel. I mean, this has come up in another with another friend of mine, another guest we had, and it just comes back to I'm so glad you said this. Like trust, and what we've said in a previous episodes, trust the journey. Like trust the journey that you're going into. That there's a plan here. So it may
Yeah.
not feel comfortable. You may feel like it's your time is better spent, studying at that point, but hang in there. There's a reason why they're having you do this.
Yeah, absolutely. And it may not be obvious to you right now, but I promise you that light bulb will go off, and it'll start to go off in your third year. And what we're hoping that we get feedback from is this next year, we will be graduating our very first class of students who have gone through our what we are referring to our shared discovery curriculum. Mm-hmm. And what we're hoping, and the ultimate goal is when they show up on July 1st, that they are as ideally prepared for that first day experience as they most possibly can be.
For residency, you mean?
For residency, yeah. Absolutely. And so really that's the end goal in mind. For those of us who've gone through this experience, we remember back I'll never forget my first day of residency and how terrifying it was. I think we're hoping that this experience will allow our students to go into residency with more confidence about their abilities to start doctoring. So,
yeah, wow. So anyway, take us into then, just as a kind of natural next step, third and fourth year. You've talked about it a little bit. It's a little different at Michigan State because you have 7 regional campuses, and like you said, they spend the first 2 years at either the East Lansing or Grand Rapids location, but then they go out and do clinical rotations at different parts of the state of Michigan. So walk us through that a little bit.
Yeah. So this sort of takes us back to the original idea and conception about our medical school. And so one of the things that we're not a medical school that likes to beat and pound our chest very much, but one of the things we do kind of, pound our chest a little bit about is that we like to promote ourselves as the original community-based medical school, or at least the original 4-year medical school. Our good friends at Penn State like to put up their dukes and fight that claim with us. And there's a subtle difference there. I believe they were the very first community-based medical school that went 3 years in length, because there was a little era there in the 60s, I believe, in which medical schools were sort of toying with an idea of being a 3-year curriculum as opposed to but we were what we like to say is we were the very first 4-year community-based medical school. And so what the traditional model meant was that you would spend your first 2 years on a traditional flagship university campus learning what they at that time called the preclinical type of information. And then what we consciously chose to do as an upstart medical school was not to build our own hospital. The idea was not for us to be a large tertiary care referral hospital system. Our idea and model was, let's put our students out throughout the state of Michigan and put them on the forefront of where medicine is presenting to them, so that they actually see that encounter and experience that encounter as a real life doctor serving, various aspects of the state is going to see it. And so the strategy was, let's see, can we develop some strategic clinical campuses? We'll actually hire clinical faculty, and pay for at least a portion of their salaries to function as a CHM faculty member in Traverse City or in Marquette. And can we then put groups of students out in the forefront, develop these strategic relationships with hospitals and medical communities, and let them complete their final 2 years of medical school there. And so that's our model, and it has continued to be that way from its startup way back in 1964.
Very cool. Very unique.
Yeah.
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 Well, so you and I had talked before the show a little bit about how students are, the first 2 years are graded pass fail.
Yep.
And you said it's a little complicated or a little confusing for how our assessment or our grading system works in the third and fourth years. So what's that look like?
Well, I would say in general, across the entire 4 years, at some level, it's a pass-fail curriculum. I think one of the things that, as we were sort of reconceiving this new shared discovery curriculum, was and breaking down those traditional silos of courses and classwork, was how do we maintain, or how do we provide a grading system that doesn't necessarily destroy sort of the departmental level of curriculum that med students experience. So at most medical schools, they're going to have in their third year what we consider sort of 6 core clinical experiences that are surrounded by various medical departments. So family medicine, or at some level, it'll be something like family medicine, pediatrics, internal medicine, OBGYN, psychiatry, and general surgery. And one of the things that I don't think we wanted to necessarily take away from our grading system was the ability for a department who was overseeing a particular aspect of a required clerkship to say, hey, this person did really awesome. Mm-hmm. However we want to define that. And so we wanted to be able to maintain at least a departmental ability for them to say on a transcript, this person got an honors grade in psychiatry. Mm-hmm. Otherwise, it remains a pass-fail system. So as far as with regards to any of the required clerkships in the third year, and maybe going a little bit that might extend into the fourth year, those required elements are given the opportunity to show up on your transcript as an honors pass-fail. The first 2 years of our curriculum, and then along with anything that would be an elective piece, reverts back to just a basic pass-fail.
Okay. Yeah, that's clear.
Yeah. Yeah. So I think the thing, though, that is confusing for some people is our assessment strategy.
Is that the script?
So it's part of the script piece. Okay. Yeah. So what Christian's referring to is when we developed this new curriculum, it was really important for us to really emphasize a concept of competency-based evaluations. And part of the reason we wanted to do that is that we knew that our residency training cohorts were doing that same thing. When they go and have their residency programs evaluated for accreditation, those accreditation agencies really place a strong emphasis on, is that resident meeting this particular level of competency in patient care? And we wanted to convert that or translate that to the medical school level. And so we came up with this mnemonic years and years ago called SWIFT, which stands for various things. And under pressure, of course, I'm not going to be able to.
I have it right here.
Service, care, patience, rationality, integration, professionalism, and transformation. I think I got it.
Yeah, that's it. Script.
Yes. And so under each one of those competency headings are some sub-competencies that specifically outline a certain sub-competency under that. And by the time they graduate, our students on a semester to semester basis create a portfolio of supported evidence that shows that by the time they walk across a graduation stage, they can show a residency program director, hey, this is what this college signed me off on. And so you know exactly what you're getting with me.
Oh, that's great.
As a care provider, yeah, you'll get an idea of whether or not I did honors in a certain area within medicine. But the truth of the matter is from a generalistic, all-round future physician, you know that this is what my skill set is right now.
It really adds some meat to that that honors, or instead of say, you can say honors, but then this gives a little bit of more flesh around that to say this is why.
This is why, exactly. Yeah. And what it does is, and as I tell our applicants, it speaks to residency program directors in a language that they understand.
Precisely.
So we're hoping that's the feedback we're also going to get a year from now when we have that ability to, in a dean's letter, show that here's the script competencies, here's the sub competencies, and this is what we promise you're going to get with our student if you say yes to them, back to them. So, yeah.
So any other highlights, Joel, you want to mention about the shared discovery curriculum? Is there anything we didn't touch on, or things that...
Yeah. Sorry. Yeah. The only other thing I want to touch on has to do with taking that competency assessment strategy and take it a little bit farther. And one of the things that I think is very, I would say, innovative in the world of higher education assessment is that we're using a semester by semester assessment modality called progress testing. Okay? And so unlike traditional assessment strategies used in higher education, which basically involve, here's the material we've covered in the last month, cram it all in the previous 2 nights, and regurgitate this back out on a multiple choice exam and crush it so that you can go home and brag to your family you got a 93% on it. Uh-huh. What we do instead is that we have contracted and constructed through the National Board of Medical Examiners a series of equivalent exams that our medical students take regardless of where they are in their training. So in a first year, first semester, first time multiple choice test, we're going to have our first year students take an exam that covers basically the entire body of knowledge of what we would consider fair game questioning for a student who's going to graduate from medical school in 4 years.
Whoa.
So that's a little bit different. And so when I tell our applicants that on interview day, sometimes I get some pretty bright eyes because the instant thing that goes through their mind is, well, wait a minute. I'm probably, if it's if I have 4 stems or 5 stems, I'll probably get a 25 or a 30 on that exam. And I look at them and I nod my head and I go, yeah. I will. And then the next thought is, well, that's not fair. And I say to them, well, I understand why you might feel that way. But one of the things that I think we really grew to find as we were revamping and relooking at how we educate students, one of the things that we really wanted to get away from was this cycle of binge learning.
Yes.
Forget it. And then binge learning it and then forget it.
Yep.
So the idea behind our curriculum is sort of this active, let's come to class prepared to engage in a conversation or a discussion about the material. Let's engage with it with our patients. Let's do it in simulation, such that, as I mentioned to you earlier, we're tricking you into studying such that every semester, that first semester, in order to pass, you got to get a 20 on that exam on one of 2 tries. Mm-hmm. At the end of your second semester, that bar starts to go up a little bit. Maybe it's a 30%. And then in the summer semester of your first year, you got to at least be able to achieve a 40%. So that by the time they get through their very first 2 years of medical school, the goal is that they're scoring a 65 or higher on that exam, which means that they're almost ready to sit in with that threshold, almost ready to sit in on a step 1 licensing exam. And from what we've been able to look at with our curriculum, at least legacy wise, our past curriculum and our students' abilities to pass the Step 1 licensing exam. Roughly a 68 on that exam is a strong indicator that you should not have an unreasonable difficulty passing that license exam. So it's a methodology that tries to build on material, and the curriculum's developed that way such that you can't study for this.
Mm-hmm.
So we're eliminating the binge learning, we're eliminating the binge testing, and then forget about it. It forces people to continue to build on what they know and continue to know and actively retain. And what we found out is preliminarily, looking at least at one class who has taken a Step 1 licensing exam, is that at least the good news is that our pass rate isn't any worse than it was in our legacy curriculum. In fact, it's at least the same. But what is more important and what's promising is that our average Step 1 score went up by 5 points.
That's significant.
Which is significant, absolutely. So, and so particularly when you take a look at our incoming student body, we think that we do a lot with that student body to get them in our new curriculum to be able to perform stronger licensing exam. And so, which then actually opens up other opportunities for them. So
it sounds like your curriculum is very forward thinking, and you've put a lot of things in place to help students at certain milestones along the way to do some self-check and do checking with the school to kind of make sure they're moving along in a process that's going to lead them to be successful and an outstanding graduate when they leave your institution.
Well, thank you. I think we think that as well, or at least we're giving them ample opportunity to be successful in whatever that pursuit is.
Any last thoughts before we wrap up this part and then dive into our listener questions? Joel, is there anything that we left untouched that we try to hit a little bit of everything from screening, interviewing, admissions committee, and then curricular highlights? Did we leave anything? Is there anything that is not found on your very nicely laid out websites that you want people to know about Michigan State?
No, our web admissions websites are pretty thorough. I would say this much, and just some things just to bring mention to them, and not that we have time to really go into them today, but I did mention very early on, that we do have some specific clinically related curricular programming and additional experiential learning for our students who in particular want to have careers in rural medicine, careers in inner city urban or international developing country disadvantaged. And for our students who envision themselves incorporating a strong public health background into the approach of patient care someday. So we have certain certificate programs that can, at the time of graduation, that the college will recognize formally as graduating with additional certification in rural medicine, or in underserved medicine for the underserved, or public health, along those lines. So we do have some specific programming for certain segments of healthcare disparity for our students who have compelling interest in that. And the last thing I'll also say too is that every year we do have what I would say a small cohort of applicants whom our committee loves, but they're just a little anxious about academic preparation to be able to be successful in medical school. So we do have, I like to refer to it as an alternative acceptance pathway, but it's a concept that was developed way back in 1990 by our current Associate Dean of Student Affairs, Dr. Wanda Lipscomb, that she coined the term ABLE, which stands for advanced baccalaureate learning experience. And so what it does is it allows a small number, about 12 to 15 students whom the committee loves, who just thinks they need an added boost, come from educationally disadvantaged backgrounds. We have them take some additional upper level undergraduate coursework here at MSU. We give them a ton of academic support, help them figure out how do they study and learn best, so that when they are asked to cram and vomit up that information on an exam, that they can do it better than what they've been able to in the past, assuming they meet the criteria of that 1 year of additional enhanced academic study and grade performance. We're holding the spot for them in that.
That's awesome.
Year. So it's a conditional acceptance pending successful completion of our ABLE program.
Oh, that's great. And that's called ABLE.
It's been great.
Yeah.
Yes.
Okay.
Great.
I'll put a link to that on our website where this episode will be archived, so people can find that quickly.
Awesome. Thank you so much. You bet.
And along you and I spoke beforehand, but you have great videos that really go into nice detail about your curricular setup. So we'll put a link onto those as well.
Wonderful.
So we're going to do some listener questions here for about experiences and activities and life experiences. And so we've received these. And so Joel and I are going to bounce these back and forth off each other. So I'll kick off the first one to you, Joel. And this one comes to us from Sally, who's at UNC Chapel Hill.
Uh-huh.
And she says, okay, when it comes to choosing your 3 most meaningful experiences in AMCAS, is there a trick to this that admissions committees are looking for?
Yeah. So, that's interesting. And I can't speak for others.
Of course.
So here's my sort of a little bit of my take on it. I would say our committee may not be as savvy at paying as much attention to that, although I think that they do pay a lot of attention to the content that's made about the applicant as they are choosing those most meaningful experiences. I will say from at least an application screening perspective, I do think it's a little unusual, or perhaps even a little risky, if at least one of those experiences is not something that's clinically related. I just think, it's just one of those things. And I don't want to turn the application process into a playing the game sort of mindset from an applicant's perspective. But I think that if in your genuineness, up to 3 of those most meaningful experiences are not directly, at least one of them is not directly meaningfully clinical. I hope that you can take whatever those experiences and then extrapolate what you learned about yourself, what you learned from them, to convey to a reader, this is why this is important. This piece will be important to me as a future physician someday. Because I think if you don't do that, and none of those experiences have a direct or an obvious link to a clinical experience, it might force the reader to wonder or question, does this person really want to be a doctor or not? Or are they doing it because their dad wants to be a doctor or something?
Yeah, exactly.
So I think it's one of those things. It's important to at least be really thoughtful about it.
Yeah, so I think I probably should have given a lead in that. So in AMCAS, you're given 15 different fields to share your experiences and activities, and you can write up to 750 characters per activity. And then these most meaningful ones, these 3 that you choose, they give you an additional 1,350 characters to expand even more on
Right.
why it was so influential. Why is this a meaningful experience? And they give you opportunity to be more reflective and evaluative on why this was the most meaningful thing. I will say, I know of a couple very research intensive programs that if you didn't choose research as one of your most meaningful, then you might not be that one of their values that they're looking for in their students is research focused students. And if most meaningful, maybe this is kind of for MSTP as well.
Yeah.
If research is not one of your most meaningful, then that could be, like you said, well, they really want to be a researcher. Do they know what they're getting themselves into as applying as an MSTP or applying to this very research intensive program? So,
Yeah. So, yeah, no, I would totally agree with you with that. So, and a good point to bring up. So, I do think, again, at least from giving advice to a future applicant, I would just say, just make sure that you're really thoughtful about that, and maybe use it as an opportunity for you to sort of indirectly convey how is it that you envision yourself contributing to the world of healthcare down the road. And letting the answer to that question maybe help guide how you choose to select those experiences.
Agreed.
Yeah. So,
all right. You have a question for me?
Sure. So, Chad from the University of Iowa writes us and wants to know, is it okay to reference experiences I've written about in the experiences section of my personal statement?
Okay. I know what he's saying here. Because I've had applicants ask me in my personal statement, can I reference things back that are in my experiences, or does the material in my personal statement all have to be brand new?
Right. I think exactly.
I think that's what he's asking there.
Yes.
And I would say that if when you're talking about personal statements, I think you can refer back to some things that you're explaining in the experiences section. It's okay, but to put that in a personal statement, but don't make your personal statement a narrative of your resume.
I think that's great advice. Yeah. I would agree with that.
Yeah. So if you're writing in your personal statement that Dr. Joel Maurer was you shadowed him and he really was a great advisor and mentor to you, I would think it's probably likely that's going to be one of your experiences, is that you write about in the experiences section, is that you shadowed Dr. Joel Maurer and this is what you did and how long and how many hours and that kind of thing. I wouldn't be surprised to see that.
Yeah, no, and in fact, I would probably almost even expect to see a little bit of that. And one of the things that you could, as an applicant, I think you could even think about in referencing that experience would be, did that experience section limit your ability to tell your whole story about that experience?
Oh, great point.
So if that's the case, then use that aspect use that your personal statement as an opportunity to fully and better develop how important that experience was in your decision making to pursue medicine. So I think it actually creates potentially some opportunities to further develop some ideas that you give us reference to in sort of that experience resume that you put in the AMCAS application.
Yeah. Okay, I've got one for you here, sir.
Okay.
Kelly from UC Davis out in California. She says, oh, this is great. She says, I'm just finishing my freshman year and my advisor told me that I should do some things outside my comfort zone because that's what medical schools like to see. At the time, I just nodded and said, okay, but I feel I'm kind of stuck and don't know where to start with that.
Yeah. So I think that's a really interesting question and a good one, because I think it's not uncommon that admissions committees like to see evidence of applicants who are willing to test within reasonable and safe levels their limits on what they can do. I think they see those those as opportunities in which a select group of people who, for the most part, are fairly successful and haven't had to deal with, or haven't had to, on too many occasions, deal with issues of resilience. But I think that one of the things that medical schools are looking for are students who are resilient, who can face challenging situations, um, develop an idea or plan, test it, and if it doesn't work, um, how can I? What did I learn about that so that I don't make that same mistake again down the road? And I think, one of the things in medicine we find for all of us is that there's going to be times in which you're going to be humbled.
Mm-hmm.
And you're gonna have an outcome in which you're gonna sit back and go, did I do everything I could have in order to prevent that outcome? And sometimes that answer might be no, I could have done better. And those are those situations that kind of push, sometimes you find yourself pushing your limits of comfort. It's easy to stay within a comfort zone. But it's when you test yourself outside your comfort zone that I think a lot of people really learn a lot about themselves. And what did you learn from that experience that's going to help you be a better patient care provider down the road? So yeah. I think a little bit that's kind of where the advisor's coming from.
Yeah, I'm trying to read between the lines here. It sounds like her advisor sees a lot of potential in her and is saying, you have a lot to offer people. And so don't be afraid to leave what you're used to here at UC Davis. I think all these campuses, we all have a little bubble over our campus. So it's very easy just to stay within the peer group. Mm-hmm. But to try to some different things, maybe within other organizations at that institution with students that you maybe have nothing in common with.
Oh, absolutely.
Or maybe to branch out a little bit and get involved in something in your community around there.
Yeah, absolutely. No, I would agree with that. And I think one of the fascinating lessons I learned as a new doctor out of residency was that you think you have control over your medical practice, but in reality, you don't have as much control over it as you think you do. And in fact, on a day-to-day basis, you have very little control over who shows up in your office to see you for your expertise. And more often than not, you're going to be caring for people who might have very different life experiences from yourself. And so having that opportunity to sort of experience life outside that which you are comfortable is really it's a good thing for you as a future healthcare provider, to try to get to know and learn as much about other people as possible. Because again, you more likely than not, you're not going to have a whole lot of say about who shows up in your office.
That's outstanding advice.
Yeah.
That's great stuff.
Anyway, well, hey, should we move on to another one?
Yeah, hit me.
Okay. All right. Well, so this one comes from James from the University of Washington. Again, this is a great question because this is one we get a lot. How do medical schools feel about putting high school experiences on the medical school application?
Ooh.
Yeah. What do you think?
Okay. I would say, think of it this way, and then we can chat about it. The things that you did in high school got you into college. It's the things that you do in college that get you into medical school.
Yep.
How about that? And then, but is there some nuance there? Maybe, I think maybe if you were a Scripps spelling bee contestant or finalist as a high school, okay, put that on there. If you did a ton of shadowing as a high school student, I don't know that you want to make that one of your 15 experiences, but I think you could be clever and allude to it in one of your more recent clinical experiences and just kind of lead it off and say, I began shadowing as a high school student and then did 1,000 hours as a high school student, but I've continued to shadow physicians as a college student and I've been shadowing Dr. Johnson more recently. I think you can allude to it, but I wouldn't take the space up. There's so many things more things you could be talking about.
I think in general you're right there, and I think particularly with that example of having some meaningful clinical experiences in high school, that might be stuff that you would put in your personal statement that helps supplement and complement the experiences that you had since graduating from high school. And so, I would agree with you in general. I mean, use that opportunity to try to tout all that stuff that you've done since leaving high school. I do think there's probably a little bit of some wiggle room, such that if you had this really unique high school experience or relevant high school experience that maybe you started in high school and then you even went on and then continued in college. Clearly you don't want to, you can't get around not talking about that. But if you have that sort of really, really unique high school experience that you think was that's a key piece as to how it is that you are that turned you into the person that you are today, it's probably fine. But I would say if you're going to do that, you got to be really cautious that it's not taking up the space of something else that's worthy of being there.
Or it could look like fluff. If you're putting in too many high school experiences in work, then it makes us kind of scratch our heads a little like, well, are they trying to fluff up their, because if you start taking out the high school things, maybe the application otherwise looks a little thin.
It does. I would agree. And in some ways, I don't know. Let's see what you would think about this, Christian.
Okay.
In some ways, depending on the situation and the applicant, I would almost rather see less than 15 experiences listed. So say he had 10.
Yeah.
Now, but let's give credence to them. Let's say these are really 10 meaningful, really awesome college or post-high school experiences, and then you supplement that with 5 high school experiences. I think what I would be afraid of is that it draws too much focus to those 5 high school experiences and maybe even forces the reader to think, they just put this in here because it's fluff, which then unintentionally takes away from the significance of those 10 really, really meaningful, or, with 3 most meaningful, with 7 very close others underneath. And so what it does is it forces the reader to keep their mind focused on what it was that you did after you left high school. And so in some ways, I would almost rather see that situation than one who puts a ton of high school stuff in.
Agreed. Yeah. So, cool.
Yeah.
All right.
Do we got time for any more? Or?
Yeah. How about, let's do one more.
Okay.
How about, here's one. Scott from Middlebury College says, I've had to work a lot during my undergraduate experience. Should I list all of my work experiences on my application or just the ones that are related to medicine?
So again, great question from Scott. And so it's one of those situations that I would say, well, it's one of those it depends sort of situations. And I would say I would lean, if you have to err one versus the other, my committee, I can tell you, they want to hear about everything.
Agreed.
Whether or not you think that it is necessarily related to medicine or tangentially or indirectly related to medicine. Because my take on it is that it lends to telling an entire story.
Yeah.
And sometimes that, as Scott alludes to, he said, I had to work a lot during undergrad, which leads the reader to believe this is someone who didn't have as many immediate resources at hand in order to get to where they are today. And sometimes in those situations, sometimes it lends itself to, as you were suggesting to earlier, I think these are the kids or these are the applicants that are worried about that imposter syndrome a little bit. I wasn't as lucky as some others, but yet somehow I wound up in medical school next to somebody who had a ton of resources, and I'm I don't know this for sure, but I'm going to guess they probably had much better grades and they had much better MCAT.
Right. Yeah. So not true.
And so this is someone who is, in particular, if they went to a school like Middlebury. I mean, I'm trying to think, if you were at Middlebury working 20 plus hours a week in order to maintain a competitive GPA, I would imagine that would be a really, really challenging situation to find yourself in. And so I think it tells a part of your story. And I think, you don't have, it's not one of those things that I think you put in there and you make excuses for. But again, it's one of those things that you say that the reality of my situation was that I needed some help in order to help put myself through college. And this was one of the ways that I did it. And through this experience, this is what I learned. Mm-hmm. Mm-hmm. And so I think that there's ways in which applicants can really put positive twists on that. Mm-hmm. I think that the applicants who find themselves in this situation worry that because they had to work, it takes away from some of the other potential experiences that they perceive to need or that they really do need in order to be a competitive applicant. I will say, at least in our medical school, that piece there is a piece that is consciously looked at by committee members.
Us too.
Yep. Yeah. And is this somebody, if we could have eliminated that piece, what do you think? Do you think the chances are that they would have had a few more meaningful volunteer experiences or an additional shadowing or
probably so?
Yeah, they probably would have. And so we give, let's just say we give contextual consideration of those situations in the decision-making process.
Yeah. I think an applicant can use that, see it as an advantage and say, you've read them, I've read them, to say, I had to work at the sandwich shop and it's something I had to do to help pay the bills and get myself through school. But boy, I learned the punctuality is important, and working with people from different backgrounds, and they're not in college and they work 2 other jobs. And boy, that was really interesting to learn other people's stories, just how they're making ends meet or taking care of their family. I mean, you can really think about what you're doing when you're there and how you evaluated that experience. You weren't just punching a time card and getting some money to help put yourself through school or pay some bills. Think of how you grew from that.
Right. Exactly. And I think that's a really smart approach in conveying your story to a medical school.
It is still important stuff.
It is. If you find yourself in that situation, don't let that make you believe that you're any less qualified than anybody else. So.
Well, listen, Dr. Maurer, this has been incredibly enjoyable. I think we've covered a lot of ground, and I think there's been a lot of little and big pearls of wisdom along the way that I hope that our listeners are going to take away and really digest it and help them in a future application. So I'm grateful for your time today.
Thank you so much. I was thrilled when you reached out to me to participate. So thank you.
Oh, you're welcome. Thank you so much, Joel. We'll see you around.
All right. You have a great day. Bye-bye.
Thank you. Well, there you go. Dr. Joel Maurer from Michigan State's College of Human Medicine. What a great episode. So much information to unpack there and digest. You can tell he is a font of experience and information. I learned a lot, and I love talking with these people to learn more about admissions and to hear more about their schools. Thanks for the listener questions. Keep them coming. If you have questions, please send them to allaccess@case.edu. That's allaccess@case.edu. And as you can see, the people that are sending us their questions are giving us their name, where they go to college, and a short question. And then we will pick it up and hopefully read it on a future episode. If you like what you've heard today, please tell a friend, tell multiple friends, tell your pre-med clubs that you might be in. Please spread the word about this. I want people to be picking up these pearls of wisdom in these episodes and sharing them with their friends. So I really appreciate it. Listen to us on iTunes, subscribe, download, and you can also find us on Spotify. So thanks again, and look forward to seeing you next time.